everyone. I'm Connie Sullivan, President and CEO of NHIA, National Home Infusion Association. I'm joined today by Bill Noyes, who's our Senior Vice President of Reimbursement Policy. And we have an important topic to share with you today regarding a new proposal from CMS that would have a significant impact on how immune globulin products are billed to all payers that use HCPCS codes, let's say in a variety of settings. Normally, we would limit access to talk infusion webinars to members only, but because of the significance of this proposal, the scope of it, and also the very short timeline to respond to CMS with concerns and the challenges that this proposal could create, we are opening this up to non-members as well, because I think there's a lot of benefits to a wide range of stakeholders potentially participating in the comment period for this proposal. So what we want to do today is basically give you an overview of what has been proposed, the timelines, some initial positions and recommendations from NHIA, and then how we will be engaging with our membership after today and what you can look for to come, and also how you can get involved in this. So I'm going to go ahead and turn this over to Bill. He's going to do the heavy lifting today with the presentation. If you have questions as we go along, please put them in the Q&A, not in the chat. So if you have technical issues, go ahead and use the chat for that. We'll be watching those behind the scenes. But as far as substantive questions, we want to get to as many of those at the end that we can, and we'll be looking to the Q&A function for that. So with that, Bill, I'll turn it over to you.
All right. Thanks, Connie. And before I get started, I'll get the most common questions out of the way. One, will slides be available? Yes, we will. If we haven't already, post a PDF of today's deck in the chat. You can download it there. We will also make this presentation available to the public on our YouTube channel. So it won't be limited to just members only. You'll be able to view it after the fact. So I'm going to start with the current state of IG coverage. Immune globulin can be covered under the medical benefit and or the pharmacy benefit. And that is driven by site of care, diagnosis, and the actual provider type providing the IG. So under the pharmacy benefit uses NDC, National Drug Codes. They don't use HCPCS codes, so these proposed changes would not affect the pharmacy benefit billing. When it comes to medical benefit, it would definitely significantly affect medical benefit billing for Medicare Part B and other insurances that utilize HCPCS-based reimbursement for drugs and biologics, which is the majority, at least in the home and alternate and site infusion space. I think that is the case for hospital outpatient department and physician office as well, but significant changes for a large portion of claims submitted. Currently, IVIG does have standard units of measure. It's just different for IVIG than it is for sub-QIG. IVIG is in 500 milligram units and sub-QIG is in 100 milligram units. And there are a couple of nuances there and a couple of drugs that cross over between, and I'll get to those when we talk about the specific changes being proposed. So I wanted to stress that these changes don't only affect home and alternate site care, they affect physician billed services, hospital outpatient physician office, ambulatory infusion centers. CMS is making this proposed modification through the quarterly HCPCS determination process. Typically, when CMS modifies HCPCS codes, they become available the following quarter. There's not a lot of debate about them. But in the case of these IG-specific modifications, CMS is proposing an implementation of January 1st, 2027, and they are requesting comment. So I take from that they understand this is a big lift and they want feedback, and we're certainly willing to provide it. So within the HCPCS preliminary determinations, this includes applications for HCPCS codes, and I think there are 36 applications. And within this document in these meetings, they will be speaking to and addressing each of those topics. And then at the very end, there's a list, there's a table, an Appendix A of HCPCS changes and modifications. And the rationale and language that CMS includes in these documents around why they're making modifications includes two important things that I've underlined here. CMS has longstanding convention to assign dose descriptors in the smallest amount that could be billed in multiple units to accommodate a variety of doses to support streamlined billing. I think really what they try to do here is to minimize waste. So you don't want to have a unit of 100 when the normal dose is 5, because you're going to bill for the whole round number of 1 and you'd be wasting 95% of that. So as we'll get to, we don't think there's a need to modify the doses and there isn't waste. The second underlined here is the route of administration. The HCPCS codes themselves don't normally include the route of administration descriptor in the code. Some of these IG products do, and the proposal removes those. So those are the two things we're going to focus on. From a timeline standpoint, CMS published these preliminary decisions or determinations on April 16th. That was as I was traveling to the NHIA conference. So we didn't really dig into this until after the conference was over, and have spent a significant amount of time since then on the information we'll share. There is a public meeting on June 1st and 2nd. It's scheduled for the 1st, but given the number of topics and based on the number of registered speakers, it may spill over into the 2nd. I expect that the IG comments will spill into the 2nd, it being the last item on the agenda. Written comments are due June 3rd, so just after the public meeting. And CMS states that they'll make a final decision on these January 1 implementation changes in October. So a very short time frame if they stick to what is proposed. I'm going to talk about a couple things they aren't addressing, because I talked about immune globulin as a whole, and there's intravenous and subcutaneous. They aren't addressing the drugs that are solely subcutaneous. So the list here, there are no proposed changes for. They are consistent at 100 milligram. They do not include the descriptor for route of administration, subcutaneous. These are standalone, stay as they are. And we are not submitting comment on the 3 following IG products that are in that Appendix A. These aren't products that we're familiar with that are utilized in our space. We don't know enough about them to submit comment. So these are excluded from NHIA's comments. Our comments do focus on this crosswalk. And on the left-hand side is a listing from top to bottom of the 12 drugs in Appendix A that we are commenting on. And on the right-hand side is CMS's proposal. So what they are doing is proposing that they delete the existing HCPCS code. So if we look at line 1 for Privigen, they're going to delete J1459, and they're going to implement a new code 1461. They're going to modify the HCPCS units for Privigen from 500 to 200. And if you read on down, you can see that most all but Yimugio were 500 in the existing column, 500 milligrams, that is. Yimugio is the most recent HCPCS approved IG product. And I suspect that CMS knew this proposal was forthcoming when they released its unique HCPCS code at 100 milligrams. So that drug there's no change for. The rest, there's deletion of the HCPCS code, a new HCPCS code, and a change in the number of units. And the number of units is not consistent. Some are moving from 500 to 200, others are moving from 500 to 100, in their proposal. The items that are asterisked here, the J1561, Gamunex, Gamukid, and the J1569, GammaGuard liquid, those can be given either sub-Q or IV, and that has always been the case. So I just wanted to point that out. They are suggesting move both of those to 200 milligrams. So what does this mean for you? Well, we're going to get into what we think it means from an administrative burden standpoint and a lot of rework that has to get done behind the scenes for claims to get processed smoothly. But from an IG dosing standpoint, the standard dosing is between 30 and 90 grams, depending on the condition being treated, the route of administration, the patient's weight. Most common is 30 to 50 milligrams. And I have an example here of a 50 milligram dose. And let's say this is an IV drug that has a current unit of measure. That's what UOM stands for, unit of measurement, of 500 milligrams. In that scenario, you would bill 100 units. And this is a hypothetical example. We're going to say that the allowable is $100 a unit and the extension, the total payment, is $10,000. By changing the unit of measure, you don't change the actual total dollar amount of the drug. You don't anticipate that the average sales price or the WAC or the ASP is going to change from a total payment standpoint. It's just that the amount per unit will straight line change based on the unit of measure. So in this example, 500 unit of measure means 100 HCPCS units, $100 a unit for 10,000. And then if it moves to 200, it's 250 units. That allowable per unit is going to be proportionately lower for the same end result in payment. And based on discussions with lots of providers, IG is almost always ordered and dispensed in whole gram doses. So we don't see an issue with waste. The current 500 milligrams, so 2 units per gram, allows for dosing in 0.5 gram units without there being any waste at all. And we think that there's very rarely fractions of a gram ordered and dispensed from a dosing standpoint. So we don't think that this is necessary from a waste standpoint. And it would create significant administrative burden. This is a very short list. NHIA is going to release our comments later this week, maybe even later today, where we'll have a long list of what we see as administrative burdens and reasons not for moving forward with these changes. But there's really burdens for all stakeholders, including providers, suppliers, ordering practitioners, payers, including Medicare, clearinghouses, manufacturers. All of the systems would need to be updated in order to crosswalk claims, prior authorizations, reauthorizations, validations. If these changes were to take place, existing authorizations would be invalid because the codes would no longer be accurate, the units would no longer be accurate. Contracting and coverage policies, formularies, medically unusual edits. I don't know if there are any in place for Medicare. I know there aren't on the DME side of things, at least ones that are public, but there may be on the physician AB Max side. But those are medically unusual edits where if your number of units billed exceeds what is medically likely, so they basically set a cap to say anything over this amount is very unlikely. And when you're moving a HCPCS unit, reducing the amount fivefold from 500 to 100, the number of units billed is going to be greater. So that may prompt denials. It interferes with the ability to track and trend data over time, something anybody looking at population health is doing from a track and trending standpoint. And the timing of the change, January 1, that is the busiest time of year when it comes to revenue cycle management and insurance company work, getting all their new subscribers into the system, re-verifying insurance for patients, getting re-auths. So not the best timing. And on their timeline, there's very little notice to get prepared and implemented. So in the end, that could result in negative effects on patient access for treatment of chronic conditions. And in our comments, we list the conditions that are commonly treated, which could lead to permanent loss of function, rehospitalization, emergency room visits, overall increased cost. And there's very real potential for billing errors due to unit of measure conversions, or on the other end, provider gets it right, payer gets it wrong. So really high area for denials. And then those in-between middleman pieces that are handling data along the way, there's also potential room for error there with the clearinghouses. From a preliminary position standpoint, and one of the reasons we want to share our comments is to get feedback. We still have some time before June 3rd, but our preliminary position is that we do not object to removing the route of administration from the existing HCPCS codes. That is the intravenous that is included on some of the IVIG products. We don't oppose that at all, but it doesn't need a new HCPCS code. Just remove the route of administration from the existing HCPCS code. But we do not believe that a change in HCPCS codes or unit of measure are necessary, and they introduce significant administrative burden without creating savings or improving patient care. If CMS does decide that there is a reason to move forward with new HCPCS codes and new units of measure, we ask that they provide transparency as to why the changes are being made. If they do move forward, we ask that they're consistent with the unit of measure instead of moving things to either 200 or 100, which seems on the surface at least to be arbitrary. I haven't found a reason why some are 2, why some are 1, but why some are 100, why some are 200. If you have any insights into that, I'd love to hear from you. So if they're going to do it, we'd like it to be consistent at 100 milligrams. That's consistent with the sub-Q IG products that they aren't proposing any changes to. Allow for an overlap of the existing and new HCPCS codes for at least a year. There are drug products out there, same product, it has 2 HCPCS codes with 2 different units of measure. Other than that, the description is just the same. So there is some precedent there, and they could do that. Require payers accept existing prior authorizations for the retired codes and units. So they could maybe automate a crosswalk from an existing PA to a PA based on these changes, crosswalking and mapping the HCPCS code, crosswalking and mapping the units based on the conversion and what in the end CMS decides. Delay implementation to allow sufficient time for stakeholders to prepare. They say that they'll make a final decision in October. That only leaves a couple of months before implementation, really not enough time. And provide a secondary comment opportunity. So if they review all the comments that are submitted and they decide there's still reason to move forward, propose it in a future HCPCS determination update with an additional opportunity to comment with whatever it is they've reworked in their HCPCS code changes. And again, I know if there is no overlap in date, there's only a couple of months from final decision to implementation. So you can imagine that for a period of time, claims aren't going to be accepted as clean. The commercial payers often lag behind Medicare in adopting new HCPCS. So it's really short time frame for cutover without overlap. NHIA actions. So we have analyzed the HCPCS code changes, narrowed in, focused on these IG that are commonly done in our space. Educate stakeholders. That's what this is all about. We've made a bunch of posts on LinkedIn, just bringing people's attention to these proposed changes. Share written comments with stakeholders. That'll happen in the very near future. Urge stakeholders to submit comments. That is what the next slide is going to be about. We are providing public comment in the public meeting. I'm registered as a 5-minute speaker. You only get 5 minutes. So there's only so much you could say in 5 minutes. That'll be on either June 1st or June 2nd. And there's an opportunity to submit written comments on or before June 3rd. That is the deadline. There, of course, you can expand and submit as long a comment as you'd like, share, and we'll share updates as they become available. So what can you do? Review NHIA's written comments, provide feedback to me. My email address is here regarding potential impacts that we haven't mentioned, areas of focus if you think it should be structured differently. And more importantly, there's power in numbers. So submit your own written comments to, and this is the email address. This is where comments are being accepted. I send them to CMS HCPCS team, and then you can just submit your comments with an attachment or an email, and they are due on or before June 3rd at 5 o'clock. So tailor your comment, review our comments. You're welcome to use what you like from them, but tailor them to your business. Different stakeholders are likely to have different impacts. Some of those impacts are downstream, some are upstream, and they tend to snowball. So if there is an issue with a clearinghouse, it's affecting the payer, it's affecting the provider, it's affecting the patient, it's affecting the ability to get paid. These aren't inexpensive drugs. There's nobody out there that can just do this for nothing. There's real costs to providing them. The service is one component, but you have to acquire the drug, provide the drug, and you have to get reimbursed for the drug. And here are a few helpful links. This is where I've got the information that I've provided. It's the Q1 HCPCS coding determination. That's the original that dropped on April 16th. The public meeting and comment information, that's where you can see the actual address, the HCPCS at cmshhs.gov that I listed on the previous slide, along with the deadline, the date for submission. And there's a public meeting agenda. Appendix A has the Appendix A, which we've kind of summarized and organized, but that Appendix A goes through all the deletions and all of the additions, and I think it'll be helpful for you to take a look at the crosswalk we provided on the slide here. The coding determinations and the public meeting agenda are very much the same document. So they put out their determinations for 36 items plus Appendix A, and the agenda follows that same 36 items plus Agenda A. So with that, Connie, I think I will ready to turn it back over to you.
All right, great. We do have a couple questions before I dive into those, though I do want to just say if you're attending this webinar and you're not already a member of NHIA, this is a good example of the type of education, resources, advocacy that we're doing on behalf of the industry. And we truly believe that if we're all working together on these things, that we are stronger as an industry and can have a bigger and better impact. So we have membership categories for just about everyone. And then if you don't fall into one of these categories, we have another kind of catch-all category. So if you're not a pharmacy, but you're maybe an infusion center, physician practice, or something like that, you are eligible for membership in NHIA, and we would encourage you to do that. We typically do limit our advocacy initiatives and education webinars to members only. So if you're finding this valuable, we'd love to have you as a member of NHIA. All right, so Bill, we can go on to some questions. So we have a question: will GAMAKID and GAMUNEX still share the same HCPCS code in the new methodology?
Yes. So if you look at that crosswalk, they do share. I don't know if we addressed that in our comments, but I would urge you to do, and maybe we'll add it to ours, but I'm not sure why it does share a HCPCS code. But I'm going to just quickly go back to that crosswalk. And it is the item with the asterisk here, GAMUNEX, GAMAKID, and here's the new HCPCS code, J1583, new proposed HCPCS code. They take out the non-lyophilized, but it's still for GAMUNEX C and GAMAKID.
It's possible we could include a recommendation to separate those codes if that's something that the industry would find valuable. I'm not sure if it's within the scope of what CMS is trying to do here, but it's probably a valid comment or request. All right, so maybe, Bill, you can kind of speak to what impact all of this might have on per diem coding changes or modifiers on drugs. Kind of any thoughts on that?
When it comes to the per diem that's utilized in the home infusion space, it's for immunotherapy. I don't expect that would change at all because the drug and nursing visits are billed separately from the per diem, but the billing of the drug itself would likely change as a result of these changes, which, if you have a prior authorization, it's likely, I don't know, you could have separate ones for separate components of the care. You may have one just for nursing and a number of nursing visits. But if you have one for the drug and the per diem, it may need to be updated. And just because you have an authorization for the per diem and the nursing, if you can't get paid for the drug, which is the majority of the expense, vast majority of the expense, then you're going to question whether or not to move forward and be looking for some assurance of payment.
All right, next question is, we have many payers that follow CMS fee schedules that are a quarter behind. So with a Q1 2027 effective date, we will have payers that would still be following the Q4 2026 rates. So it seems, and this is maybe more of a comment, but you can add to this if you like, it seems like delaying this to at least the second quarter is the only way they can accommodate this for payers.
That's a great point. And I think I said, if I didn't, I should have, that commercial payers often lag behind Medicare in their adoption of the HCPCS codes, utilization of the fee structures. So that's a perfect example of this affecting more than just Medicare beneficiaries.
I think we have plenty of time for a couple more questions. We'll leave it open for a minute. I guess the other question here, it was just submitted, is it taken into consideration that in addition to being the busiest time of year with benefit verification, that providers will have to obtain all new prior authorizations? I think the simple answer there is yes. We realized that and did include that in our very lengthy comment letter that we will share. Probably not today, but probably, hopefully, either tomorrow or Friday. And that'll be on our website. And a lot of people have mentioned they've had trouble downloading the slides. I believe when we do webinars, if you've attended today, you should receive an email with a link to the recording and the PDF of the slides. One question about any changes to pumps?
No, this is specifically limited to the drug and the drug HCPCS code units themselves. So it wouldn't change the EO781s or EO779 drugs that are sometimes utilized in the Medicare benefit. And there are often changes to drug HCPCS codes, but the pump itself, the coding, the amounts all stay the same. So while they're within the same policy, local coverage determination, a change to the drug HCPCS code wouldn't affect how the pump is covered. Although those policies and the details within the policies as to what HCPCS codes are covered would all have to be updated. So for Medicare, there's a big lift here too. You've got LCDs on the DME Max side. You've got LCDs on the AB Max side. They all get into detail as to what drugs are covered. They link the HCPCS codes to those drugs. They link the diagnosis, the conditions of coverage to those HCPCS codes. They'd all have to get reworked. The ASP files would have to get reworked to that person's point. If it goes from 500 in Q4, 500 milligram unit in Q4, and it's $100 a unit, and it moves to Q1 at 100 units, you're going to see an allowable for that drug with a different HCPCS code of an amount 1/5, so $20 a unit. It may even change the way, I'm not sure how the drug manufacturers report to CMS sales and how that plays in the ASP calculation. I'm not sure if they do it in grams or they're required to do it in actual HCPCS units, but that would be a pretty big quick lift. They had to modify those calculations.
Another question, Bill, is will there be any coverage criteria changes, or does everything else remain the same?
This doesn't necessarily prompt a coverage change determination. I wouldn't expect that it would. And I have kind of wondered the same thing. what is it that they're trying to get at here? If it isn't waste, what is it? Are they looking to cover less? Are they looking to change the way it's reimbursed? I don't think so. I don't see how it could.
And that,
I mean,
yeah.
these drugs, the coverage that at least we utilize in the home, I know it's a little bit different in the physician office, and they can do a lot more off-label administration for Medicare than we can in the home environment. And it's very condition-based for Medicare Part B, and it's only FDA-approved conditions. These drugs would continue to have the same FDA-approved conditions. They're just changing the HCPCS code and the unit of measure related to those drugs. So wouldn't really see it changing the conditions of coverage.
Yeah, we had another person commenting about, do we know what precipitated the suggestion for these changes? And I think you just basically addressed that. We're speculating. If we just go off of what they have published in their reasoning, you already addressed that early on, and sometimes it's just a waste to prevent waste, but that doesn't seem to be applicable here. So we're scratching our heads a little bit here to understand why they would introduce a change that would clearly provide a lot of disruption and administrative burden, which is obviously what we would share. Our position here, our kind of strongest position, is that there's no reason for this change. And so to not go forward with it at all. And secondly, if they do, we need much longer timelines for implementation and some overlap and a little more transparency about what the ultimate goal is here.
There was a time years ago, I don't even remember which IGA drug it was, but they had a proposal out there to make the unit of measure 127 milligrams. It was something crazy. And I did comment that they should keep it consistent at 100 milligrams, and they did adopt that, and they did make the change. So I think the silver lining here is that they're asking for comment. And I'm hopeful that they'll get lots of comments. I know they'll get our comments, and there's got to be some return for this work. And CMS has been very vocal about reducing administrative burden and patience over paperwork and streamlining prior authorizations. And this all really flies in the face of that without any return, without any savings, without any benefit to patient care.
We haven't had any new questions come in at this point. We've made some notes. We appreciate the comments around ASP delays and the impact that might have. And that's something we can make sure to incorporate in our comments as well. I think mostly the takeaway here is that I think when it comes to comments to CMS on this, more is better. They don't have to be overly technical. They just need to echo the concerns that I'm sure all of you would have if you had to implement this change in this timeline. You can certainly use NHIA's template, copy and paste as you will, or just say we support NHIA's recommendations. That's simply fine. But I do think that the more feedback they hear, and we will be obviously reaching out to some other industries as well to make sure they're weighing in on this, the more likely it is that they will heed our recommendations. So it's very worthwhile, I think, in this case, for everyone to participate in this comment period. We will also be part of is that hearing something, Bill, people can listen to? Is that public or how?
It's public to listen to. The deadline to register to be a 5-minute speaker has passed, but you can listen in, yes.
So Bill will be representing NHIA on that call. Yes, we will share the slide deck and recording. So I'll put out one last call for questions. All right. I think we have captured hopefully all the questions and comments. Thank you all for participating, and watch for more updates in Infusion Express, our email newsletter, and through the community in terms of when our comments are available. Right. Thank you very much, everyone. Have a great rest of the day.
Thank you.